Okay, so now we're going to talk about the appendicular skeleton. This is the part two, but it's our third recording for this chapter 7. So the appendicular skeleton refers to the appendages, which is a part that is going to be joined by something larger. Remember, of your appendicular skeleton, we have 126 bones. The primary function, and that's just of the appendicular. So the primary function is going to be movement. It's going to include the upper and lower limbs. It's going to include the girdles, which is the parts that attach the limbs to the exoskeleton. So again, right here it tells you the subtotal for the appendicular system is 126, but the total adult skeleton is at 206. Okay, so each upper limb has 32 bones, two separate regions. The pectoral girdle, which is the shoulder, the next one have 2 bones, and the 2 bones, of course, the clavicle and the scapula. And then the free part is 30 bones. So the free part is going to be like the humerus, the ulna, the radius, the carpals, metacarpal, and the phalanges. So this right here is just showing you the pectoral girdle, which is going to include the clavicle and, of course, the scapula. Okay, so you see this is the posterior view. This is your anterior view of it, the skeleton. So the pectoral girdle consists of 2 bones. Again, like I showed you on the picture, it's the scapula and the clavicle. The free part is the bones in, of course, the arm. So it'd be the humerus, which is the upper arm, the ulna, which is the forearm, the radius, which is in the forearm, and the 8 carpals, which is in the wrist. And then you have 19 metacarpals and phalanges in the hand. So just remember that the girdle, pectoral girdle, which is the scapula and clavicle, they're going to connect the upper limb to the exoskeleton. So first you have the clavicle. It is an S, you can kind of like a very slight S-shaped bone, so it is S-shaped. If you can feel this one, of course, through the skin, it's because it creates a bulge in the skin. This one's also known as your collarbone. It is a type of long bone. So the medial end, of course, of this um, bone, of course, is going to articulate with the manubrium of the sternum, forming the sternoclavicular joint. The lateral end is going to articulate with the acromion. The acromion, of course, is going to be the highest point on the scapula, and it forms the acromioclavicular joint. So this is going to serve as a support to the scapula and the free limb, allows the arm to have maximum range of motion. Again, this is showing you, of course, the clavicle enlarged. You have the lateral end. Remember, the lateral end is going to articulate with your acromion, and acromion is that highest process on the scapula. It forms the acromioclavicular joint. On the medial end over here is going to articulate with the manubrium, okay, and it forms a sternoclavicular joint. So the clavicle is going to be convex and concave. So when it's convex, it's that referring to the shape it's anteriorly near the sternal junction. The clavicle is going to be concave. That means it's anteriorly on its lateral edge, of course, near the acromion. And for some reason that word did not get on there, so I'll write that on there for you. So the clavicle, of course, is or can be easily felt through the skin because it's only covered with skin, the biggest portion of it. It doesn't have a lot of muscle over top of it, so that's why you can feel it easily through the skin. All of your other bones are covered with a lot more muscle. So you have clavicle fractures, of course, are going to be extremely common. So a broken clavicle in infants, though, is usually occurs during birth. So we also have a term called FOOSH, and what that means is a fall on an outreached hand. In some cases, it could be on the arm. But what can happen here is the injury can lead to a fractured clavicle. And your clavicle is actually going to be the weakest at the junction of those 2 curves. Okay. So most breaks occur approximately in the middle of the clavicle. Uh, the scapula, of course, is also known as, aka, the shoulder blade. It is triangular shaped. Most notable features include the spine, the acromion, the coracoid process, and the glenoid cavity, which we'll go over on the next few slides. But the scapula, of course, is the bone that connects the humerus arm with the clavicle bone. The spine, what it does is it separates the supraspinatus fossa and the infraspinatus fossa. Okay, and this right here is the spine of the scapula through here. And then, of course, this is your supraspinatus fossa here, and this, but down here, this whole area here would be the infraspinatus fossa, whereas up here above it is the supraspinatus fossa. So it is a large process. Superior, it's going to be posterior of the scapula. It ends laterally as acromion. So it ends. So the acromion is actually part of that spine. So the acromion end is the process that ends it. Acromion, of course, is just the flattened lateral portion of the spine. What the acromion does is it helps to stabilize the shoulder joint. And of course, also the acromion, again, remember it's going to articulate with that clavicle on the lateral end of the clavicle. This is showing you, of course, we've already talked about just now the acromion here process, or the acromion. Make sure you can label it. Make sure that you can label the coracoid process. That's the smaller process. So the acromion, of course, is the highest point of the scapula. Then the next one is the coracoid. So coracoid projection or process is a projection on the anterior surface. It's inferior to the lateral aspect of the clavicle. It also is going to help stabilize the shoulder joint. So the glenoid cavity, that's this area here. That's a shallow concavity that articulates with the head of the humerus. And sometimes on the test I'll ask you, the glenoid cavity articulates with what bone? And that would be the head of the humerus. Medial border, which is also known as your vertebral border, and then you also have the lateral border with auxiliary border. So the vertebral or the medial would be over here. The auxiliary border would be on this side. Okay, so the auxiliary border is closest to the arm. Then you have a top one here, which is the superior border, or the superior edge. So make sure that you can label all the borders. And again, depending on what book you're using, some use medial, lateral, superior, and some use the auxiliary, vertebral, and superior. Okay. Make sure that you can name the angles as well too. Scapular notch, which we'll talk about in a minute, that's right there. Superior border, acromion, coracoid process, glenoid cavity. The two fossas that we just talked about previously. So your inferior angle would be, of course, the angle where they kind of come down and meet here. That's at the bottom. So it's medial and lateral borders meet inferiorly. And then when you have your uppermost part of the scapula, you have the superior border and the medial border meet. That's called the superior angle. Supraspinatus fossa, again, you do make sure that you can label it, and infraspinatus fossa. Those are going to be important to know and understand, because when we get to the muscles, we have a muscle that's named after those sites as well too. So it's just the posterior concavity of the superior to the scapular spine is the supraspinatus fossa. It's attachment site for the supraspinatus muscle, so you can see where it gets its name. Okay, so it's above the spine. The infraspinatus fossa is posterior concavity inferior to the scapular spine, and that's this area through here, and that's the site of the infraspinatus muscle. The subscapular fossa is anterior concavity, of course, where the subscapular muscle attaches. And this is showing you the posterior view. That fossa is going to be on the anterior view. So it's going to be on the anterior side. So that's why it doesn't show on this picture. But one thing that students will sometimes ask me about is what they refer to as scapula winging. And scapula winging is when you have several muscles that are attached to the scapula but do not function correctly. And what it does, it causes the scapula to stick out a little bit in the back. So number one, what is the function of the pectoral girdle? That's to move the arm. So the arm has a maximum range of motion. It also is going to connect the upper limb to the exoskeleton. Uh, Number two, I gave this to you in your notes, what part of the clavicle is its weakest point, and that's in the middle, which is going to be at the junction of the two curves. Number three, which point of the scapula forms the highest point of the shoulder, and that's going to be your acromion. So you have the humerus. That's what we're going to talk about next. It is a type of long bone. It is the longest and the largest bone in the upper limb. The proximal ball, of course, is the shaped end that articulates with the glenoid cavity of the scapula, and you can kind of see it a little bit here. The distal end articulates with the elbow, with the radius, of course, and also the ulna. Some special surface features of the humerus. The head of the humerus has two unequal size projections, and you can see those here. This one right here and one right here. The greater tubercle lies more laterally and a little bit posterior, and it's greater. It actually goes all the way around a little bit. And the lesser tubercle lies more anteriorly, and it's a little bit smaller. So that's how it gets its name, greater and lesser tubercle. So both of these, the greater tubercle and the lesser tubercle, both are going to serve as an attachment point for your muscles. The intertubular groove or sulcus, and I'll kind of use my blue ink here. That's this groove in between those two tubercles. So it lies where the long head of the biceps brachia tendon, of course, is going to be located. So, and also a large tendon runs along that groove as well too, that attaches that biceps brachia muscle. Anatomical neck. That's the distal to the head, and it looks like a line, but it marks the extent of the joint cavity. You have the surgical neck, which is where the tubular shaft begins and is a common area of fracture. Deltoid tuberosity is about mid-shaft on the lateral aspect, and it's a roughened area, and that's where your deltoid tendon attaches. So if you look here, you have the anatomical neck here. It shows you on the little lines here. And then, of course, you have the surgical neck down below. So the surgical neck is when you have where you have the most fractures. And be sure to be able to label all these bones of the pictures, the details that I'm pointing out to you. Capitulum and trochlea. The capitulum is a round knob-like process on the lateral distal humerus. And you can, of course, see it on this side. It's on the lateral side. Okay. The trochlea is on the medial, and I'll kind of use a different color for it. It's kind of a spool shape, and of course it looks like this, has spool shape. So that's the trochlea. It's built to the capitulum as a spool shape projection on the distal humerus. So what you need to know here is the capitulum. Of course, the function of it is it's going to articulate with the radius. and that's the cup-shaped depression of the head portion. The trochlea, of course, is going to articulate with the ulna. And the specific area on the ulna is going to articulate with is going to be the trochlear notch. So next we have two fossas. We have the coronoid fossa and the olecranon fossa. The coronoid fossa is the smaller of the two. Okay, it's also going to be on the anterior side, whereas the olecranon fossa is going to be the larger fossa, and it's going to be on the posterior side. Okay, so the coronoid fossa is going to receive the coronoid process of the ulna during your forearm flexion, and then the olecranon is going to receive the olecranon of the ulna during your forearm extension. Next, we have, of course, the medial and the lateral epicondyles. You have a bony projections to which the forearm muscles attach. You can feel both of those, and you have, of course, this right here is your medial epicondyle, and this one over here is going to be your lateral. Okay, both those are bony projections. You can feel both of them. The medial epicondyle is going to be larger, the larger projections of the two. So medial is larger. Again, this is showing you, of course, the picture of the humerus. It also shows you, of course, the glenohumeral joint. But just make sure that you can label the pictures. This is just giving you the basic information. But some pictures up close will show you a little bit more detail. Make sure you could label all the parts that we're going over. So the ulna, this is, of course, also a long bone. And it has a U-shaped portion on it right here. Okay. So it's the longer of the two forearm bones. It's located medial to the radius. It contains the olecranon, which is a large prominent proximal end, also known as your tip of your elbow. So I always tell people that the olecranon here, it forms, of course, forms your elbow. And it's going to articulate with that olecranon fossa. Next, you have the coronoid process, which is this process here. Make sure you can label it. Again, the olecranon's here, and of course the tip. Sometimes the books will call it the olecranon process. Okay, so both of these is what they refer to as the lips. So the coronoid process is the anterior lip of the proximal ulna. The trochlear notch, which is this notch in the middle, it's also known as your semilunar notch. And it's a deep fossa that receives the trochlea of the humerus during your elbow flexion. The coronoid process, I think I told you that, articulates with the coronoid fossa on the humerus. One thing to go back, because I'll go over the styloid process in just a second, but with the ulna, the head of the ulna is on the distal end, whereas most bones, the head of the ulna is going to be proximal. So head of ulna is on distal end. So on the distal end, you have the head of the ulna, and then you have below it, you have the styloid process. So the styloid process, of course, is a thin cylindrical projection, which is on the posterior side of the ulna's head. Again, I like to show lots of little pictures, but this one shows, of course, like the anatomical neck, surgical neck, the head, greatotubercle, mesotubercle, the intertubercular sulcus. So make sure you can label all those: scapular humerus, deltoid tuberosity, coronoid fossa, and this is showing you anterior view versus the posterior view, so you can see both, because the olecranon fossa will be on the posterior side. Trochlea, capitulum, coronoid process. So make sure, condyles, your lateral and your medial. So make sure that you are able to label those on the picture, or our picture very similar. So radius, of course, lies lateral to the ulna, is on the thumb side of the forearm. The head, of course, which is disc-shaped, and the neck, of course, are going to be on the proximal end. So the head is going to articulate with the capitulum of the humerus. So the radial notch of course, of the ulna. Radial tuberosity, of course, it shows you, of course, that's that roughened area here. I don't make you label that one usually on the picture, but it's the medial and inferior to the neck. It is an attachment site for the biceps brachii muscle. You also show the styloid process on the radius and the ulna. So on the radius, it's over here. The styloid process on the radius is on this side, excuse me, and the ulna on this side. So your styloid process, you have large distal projection on the lateral side, of course, of the radius. So the brachioradialis tendon is actually going to attach to that styloid process. Okay, the shaft of these bones are going to be connected by what they refer to as an interosseous membrane, and you can kind of see that in between the two bones. Again, on the thumb side is the radius. On the pinky side, for your pinky finger side, that's going to be the ulna. But there is a proximal radio-ulnar joint and a distal radio-ulnar joint. So the interosseous membrane, of course, is a thin, broad plane of fibrous tissue, and it connects the radius, of course, and the ulna together. The proximally, the head of the radius articulates with the radial notch of the ulna. So on the radius, you have the radial tuberosity here, and then on the ulna is the notch, radial notch, so that articulates. So up here, you also have the head, the head of the radius, and then of course the notches on the other side of that. Then distally, you have the head of the ulna is going to articulate with the ulnar notch, of course, of the radius. So you have the head member of the ulna is always distal, and then then it's going to, of course, the head of the ulna is going to articulate with the ulnar notch, of course, on the radius, which we don't make you label that one. So make sure that you can, of course, label this, that the olecranon is up here, trochlear notch, coronoid process, radial notch is right here, and that's where the head of the radius is going to articulate into the radial notch. And next you have the skeleton of the hand. You have the carpus, which is the wrist. It consists of 8 small bones, which are the carpals. You have 2 rows of the carpal bones. You also have a proximal row of the metacarpals, which is the palm. You see the palm of the hand. You also have the distal row, which is the fingers, phalanges. And on the actual fingers, you have 3 bones. On the thumb, you have 2 bones on the phalange portion. One bone that you do need to know, of course, in the carpals, on the wrist bones, is a scaphoid bone, and that's the most, and here's why you need to know it, that's the most commonly fractured bone in the wrist, and that's on that proximal row of the carpals. You can see it here. So it's located between the hand and the forearm of the thumb side, and it's also the scaphoid bone is also the largest wrist bone. You have 5 metacarpals, which again are going to be in the palm, and they're numbered like Roman numerals 1 through V for 5. They're lateral to medial. 14 phalanges. You have 2 in the thumb, which is the pollex. You have 3, of course, in each of the other fingers. And that's where I was showing you here. You have 2 in the thumb, and 1, 2, 3, in each of the fingers. Again, once you have time, this software that I'm using won't let me play the video while I'm recording. But you can pull your PowerPoint up in presentation mode and play the videos. So how many bones are in the wrist and the hand? So you have 8 carpals, 5 metacarpals, 14 phalanges. So in one hand you should have 27 bones in one hand. What is the name of the longest and largest bone in the upper limb? And that's of course going to be your humerus. So the skeleton of the lower limb, is by 2 separate regions. There's a single pelvic girdle, which is 2 bones, and the free part, which is going to be 30 bones. The coxal bone, which is your hip bone, it consists of 3 bones that fuse together. That is the ilium, and we have it color-coded here for you. The pubis bone, which is in gray, and it looks like kind of a reddish color, is the ischium bone. The pubic symphysis, so if you look at the 2 coxal bones together with the sacrum, you have a fibrocartilage joint in the middle here, and that's called this area here where the 2 hip bones join together anteriorly. That's called the pubic symphysis. So they're joined posteriorly by the sacrum in the back. Okay, and they form what they call the sacroiliac joints. Of these 3 fused bones of the coxal bone, the ilium, of course, is the largest of those 3. Again, make sure that you're able to label this picture. Again, this right here forms the sacroiliac joint. This up here in the front is going to be the pubic symphysis. You need to be able to label the obturator foramen, which is the largest foramen in the body. The acetabulum, which is that socket. Be able to label this as the sacrum, hip bone. Also, of course, be able to tell which one's the ilium bone, ischium bone, the pubic bone, which they was fused together. So your ilium, of course, is the superior part of the hip bone. That is the largest of the 3 hip bones. And you see it here. It's the one part that's not colored. The acetabulum, of course, that is the socket here inside. That's the socket for the head of the femur. And the acetabulum, of course, like I said, is also going to articulate with that head of the femur. The acetabulum is also formed by all 3 bones. As you can see, that is color-coded. Superior border. Let me erase this real quick. So the superior border is called the iliac crest. That's the top of the hip bone here. Also, too, you have what we know as the hip pointers, and that occurs at the anterior superior iliac spine. And that is just this little pointy piece here. So it's on this side's anterior and this side's posterior. So this would be the anterior superior iliac spine. Down below would be anterior inferior iliac spine. Okay, so when we're in lab, we'll go over those in a little bit more detail. Hip pointer, when you have the pelvic girdle together, of course the hip pointer occurs at the anterior superior iliac spine. The greater sciatic notch is right here. Okay, that allows the passageway of the sciatic nerve. You have your ischium bone, which is the inferior and posterior part of the hip bone. The ischial tuberosity, of course, that is this roughened area here. Okay, that's the part when you sit down in your chair. That's the part that you're actually sitting on. Okay, pubis, of course, that's this other bone here, the gray bone. That's inferior and anterior part of the hip bone. It contains the pubic symphysis, which joins the left and the right hip bones together with that fibrocartilage. Obturator foramen. This is, of course, formed by the ischium and the pubic bone, and nerves, of course, and muscles are going to pass through it. And it is the largest foramen in the body. Again, this is showing you, of course, all the parts of the right hip bone. So you do need to be able to, of course, label the iliac crest, which we've talked about. We talked about the anterior superior spine and the anterior inferior iliac spine. And we will have another one, the posterior ones on the back, so you do need to know those. We'll be able to label those. Know, of course, the acetabulum, the obturator foramen, the greater sciatic notch, be able to label that. The ischial spine, which is this spine here, and the lesser sciatic notch, which is underneath it, ischial tuberosity. So be sure to be able to label those. Again, once you have your PowerPoint in presentation mode, you can play your video. It will not allow me to play it on this software. So males, comparing male and female pelvises. So males' bones are larger and heavier. They have the pelvic inlet is going to be smaller and heart-shaped. They have a pubic arch is less than 90 degrees. A female has their pelvis is wider and shallower. The pubic arch is greater than 90 degrees, and it has more space in the pelvic inlet. So you can determine if you have a skeleton as the only remains of the person, then you could tell if it was a male or female by the pubic arch size. This right here just shows you a comparison of the male and the female with the general appearance that we've already went over. The differences in the ilium, sacrum, iliac fossa, the pelvic inlet. The pelvic inlet, of course, you can see the big difference. It is, of course, more open and wider in the female versus the male. Coccyx, of course, in the male is going to point more anteriorly, and it points more inferiorly in the female. Obturator foramen is actually a little bit different size as well too. It's more oval here in the male, and over here it's more triangular looking, which I cannot draw very good there. Pubic angle, again, this is the main one I ask a lot about. Usually it's male's less than 90 degrees, female it's larger than 90 degrees. So if a skeleton has a pubic arch of 105-degree angle, is it a male or is it a female? And it'll be a female. Define pelvimetry. What that is an assessment of the female pelvis in relation to the birth of a baby. So it's used to decide if a natural vaginal birth is possible or if they need to use a cesarean section. Next we have the femur, which is the longest and heaviest and strongest bone in the body. As proximally, the head articulates with the acetabulum of the hip bone, forming the hip coxal joint. So it contains also the head of the femur. It has this little indention on the end of it. It contains what they refer to as the fovea capitis. And that fovea capitis is just that small depression in the head of the femur. And it's a ligament that attaches to the fovea capitis that also attaches to the acetabulum to help stabilize it. Next, you have the neck area here of the femur, and it's distal to the common site of fracture. Usually the neck is when you have a broken hip, it's usually where it occurs at. Not all the time, but where it most often is associated with a fracture in the neck of the femur. Medial and lateral condyles are going to articulate with the condyles of the tibia, forming the knee joint, also articulates with the patella. And then, of course, you have your medial condyle on this side and your lateral condyle on this side. Next, you have your greater and lesser trochanters. They are projections where large muscles attach tendons. The greater trochanter is the landmark commonly used to locate the site for intramuscular injections. So make sure that you know that one. That's the landmark or the site for intramuscular injections into the lateral surface of the thigh. The gluteal tuberosity and the linea aspera that is attachment sites for the large hip muscles as well too. The intercondylar fossa, that's a fossa back here. That's the depression between the two condyles. You can't see it right now because the patella bone is covering it. It's on the posterior side as well too. The medial and lateral epicondyles is the muscle site attachments for the knee muscles. So the knee joint muscles attached to it. So right here you can see, of course, that intercondylar fossa, which is on the mostly shown on the posterior side of the bone. So I wanted to show you that as well too. Again, the greater trochanter, remember that's that attachment site for muscles, and that's also going to be used as your landmark for intramuscular injections. Okay. The patella, that of course is your knee bone, is going to form your patellofemoral joint, which is also known as your knee joint. That's the largest sesamoid bone in the body. It has, of course, many ligaments that we'll talk about later, and when we get to the joint chapter, we'll talk about the ACL, PCL, and meniscus when we get to that chapter. But the patellofemoral stress syndrome is also known as your runner's knee. That's the most common problems with runners, is when they get too much stress or tension on the joint. It's more inferior and narrow surface is going to be at the apex, and the base is going to be the superior surface. The patella is a thick articular cartilage that lines the superior surface, increases the leverage of the quadriceps femoris muscle. So up here, this area is where you have the attachment site for the quadriceps tendon or muscle. And down here in this area, that's where you have the attachment site for the patellar ligament, which then attaches the patella to the tibia. So your tibia, which is also known as your shin bone, is a larger medial weight-bearing bone of the leg, and it's stronger. Contains the lateral and the medial condyles. Its proximal end is going to articulate with the femur. It articulates distally with the talus, which is a tarsal bone, and the fibula. And of course, you see your talus bone here. Your tibial tuberosity, that is the roughened area here. That is the attachment site for the patellar ligament. You have your medial malleolus, which is only on the tibia bone, that is down here. That is the medial surface of the distal end, so it's the middle surface of the ankle joint. So your malleolus is the bony projection on each side of your ankle. So the medial malleolus is on your tibia bone, the lateral malleolus will be on your fibula bone. Fibula, of course, is the smaller lateral place bone on the leg. You have non-weight bearing. The head forms the proximal tibio-fibular joint. That's going to join the fibula and the tibia bone while allowing motion. The lateral malleolus is only on the fibula bone. Its distal end articulates with the tibia and the talus at the ankle, and that's what they refer to as your lateral ankle. So the fibula is going to be on the lateral side. Again, this is just showing you a picture of the tibia and the fibula. This is showing you enlarged the medial malleolus off of the tibia. Next, you have 7 tarsal bones. The talus, you need to know it articulates with the tibia and the fibula, and the calcaneus, which is the heel bone, and that's the largest and the strongest. You have 5 metatarsals, 14 phalanges, and the big toe is called the hallux. The tarsus, that's just a cluster of bones in the foot between the tibia and the fibula and the metatarsus. This is just showing you those, the talus here, and then the calcaneus bone here. Again, you can watch this video in the PowerPoint. Arches in the foot, you have 2 arches that support the weight of the body. They provide spring and leverage to the foot where you're walking. The arches flex when the body weight is applied. Flat foot is happens when your arches are going to decrease or fall down. That could be caused by too much weight or excessive weight. Also, it can be caused by weakened tissues. It can also be a genetic disorder, and also posture abnormalities can cause that as well too. Clawfoot is when you have too much arch that occurs due to various pathologies, and that's caused by muscle deformities. This right here is just showing you a picture of dancer's fracture, and that's a fracture here, of course, of the fifth metatarsal. It usually occurs while the body weight is supported, of course, while the foot is in an arch position. Again, here's a video on the foot you could watch. So recap here, of course, how many bones, of course, are in the foot. You should have 26, that'd be 7 tarsals, 5 metatarsals, 14 phalanges. Define bone grafting, that's when you have a surgical procedure where they replace bone with material from the patient's own body or artificial synthetic substitute. What are the functions of the arches of the foot? And it's going to provide spring and leverage when body's weight is going to be applied.